and getting online and getting started, please take a moment if you can to share with us in the chat who you are, where you're from. If you feel so inclined, we'd love to see your faces. Feel free to pop your video on and off, or especially during the kind of case discussion. We'd love to hear your thoughts or burning questions you may have. It's also important to please know that you can receive CME credit for participating in these sessions. For physicians, Project ECHO designates this as a live activity for a maximum of 1.0 AMA credits. And you can claim that through a link that we'll share with you in the chat. For nurses, you also can have a maximum of 1.0 ANCC contact hours and credit. So again, pay attention in the chat at the end of the session. Please know that all of our sessions are recorded and data is collected, and we really use this just to help improve the process forward, meet the needs of what you're looking for, and just continually, make improvements. So everything will be recorded and collected, but of course it's confidential. And then we use this for reports, maps, communication surveys, and to sort of inform new programs. So please, we would ask that if you do share questions, please just remember not to share any personal health information, just for the confidentiality of patients. And then throughout this whole process and afterwards, if you have any questions, you can definitely email us. That information is in the in the chat, but it is a.goodman@hemophiliafed.org, Hemophilia Federation, hemophiliafed.org. So for this session, just like the others, we have our quick brief introduction. Then Dr. Kristina Haley, who is our wonderful guest speaker today, will take us through her didactic presentation, and then we'll go through some sort of clinical vignettes that hopefully will spark some good debate and questions and help inform you guys. And then we'll have a quick wrap up. You will be muted during this session, but certainly feel free to mute and unmute, turn your video on and off, add into the chat if you would like. So moving forward with today, again, this is our third in a series of 4 sessions on the topic of heavy menstrual bleeding and bleeding disorders. And specifically, Dr. Kristina Haley is going to talk to us about iron deficiency and bleeding disorders. To tell you, I think first, actually, if we can pop up the slides, we do have a brief disclosure statement that you can take a moment and just review about all of our guest speakers, as well as our support staff and the disclosures that they have. And with that, I would like to introduce today's guest speaker, Dr. Kristina Haley. She is the director of the Hemophilia Center at Oregon Health Sciences University. She also co-directs the OHSU Spots, Dots, and Clots Clinic, which is a combined hematology gynecology clinic for adolescent women with bleeding and clotting disorders. Dr. Haley spends time educating medical students, residents, and fellows, as well as community health providers on all things non-malignant hematology, and specifically an emphasis on the care of women and girls with blood disorders. Dr. Haley's research includes projects aimed at characterizing the symptoms, treatments, and the impacts of bleeding in women with bleeding disorders through a national data set, as well as improving the understanding of platelet disorders. And with that, I will let Dr. Haley take it away. Now, as we do with every session, we do have sort of pre-session poll. And again, I'll let Dr. Haley kind of guide you through that, but basically some questions for you to answer, and then we'll do it again at the end of the session.
Great. Okay, so the first question on this pre-poll is, according to a 2014 study evaluating iron losses in menses, women with heavy menstrual bleeding had how many times higher losses of iron compared to women with normal menses? And you can pick your answer of A, 0.5 to 1 times, B, 2 to 3 times, C, 5 to 6 times, or D, 10 to 12 times. And you can go ahead and select. I can't remember. I'm having a blank, even though I've done this every time. I can't remember. Do we just move on to the next one, or people will submit?
Yeah, I believe everybody has to answer all 4 questions before they can submit.
Great. Okay, that's what I couldn't remember. Sorry, I was having a moment. Okay, so question 2. Which of the following hinders intestinal iron absorption? A, red meat, B, dairy products, C, ascorbic acid or vitamin C, D, iron deficiency, or E, fasting. So think about what blocks iron absorption. And then the final poll, oh no, sorry, there's 4. I'm learning to count. According to a 2013 review of patients with von Willebrand's disease, what % of females had iron deficiency? Well, only 4% of men with von Willebrand's disease had iron deficiency. So the options are there. And then 4, which of the following is not a very frequent symptom of iron deficiency anemia? And we have our options there. Great, now I see answers coming in. So exciting. Okay. Great. I'll give it a second more, get a couple more answers. Then we'll answer all these questions in the moments ahead. Get excited. All right, do y'all think I can go ahead?
Do you want me to share the results or should we?
Oh yeah, I forgot
Wait
about
till
that,
later.
you guys.
Okay,
It's
that's
like
fine.
it's like I've just joined this thing.
So we should be able to see results now, I think.
Okay. Do I stop this? Oh, there. Now share results. Okay. So seems like feeling like definitely women with heavy menstrual bleeding have more iron losses than those without. We'll come back to that. Dairy products hindering intestinal absorption. More women than men having iron deficiency with von Willebrand's disease, and then dyspnea and headache or syncope are all up there. We'll go through that. So, all right, awesome. Thank you for your participation. Let's talk. Oh goodness, sorry. How do I get out of there? Okay, we're gonna go to iron deficiency and bleeding disorders. I'm super happy to be here. I love talking about iron deficiency, so I'm glad you're all here. Our learning objectives today are to recognize the signs and symptoms of iron deficiency, recognize these symptoms as well as the undertreatment of this condition in the setting of heavy menstrual bleeding and bleeding disorders, confirm which labs we want to order, and recall how to interpret those labs in our next steps. I love this quote from Nancy Andrews and her co-authors of one of like the textbooks of pediatric hematology, that iron lacks the glitter of gold and the sparkle of silver, but outshines both in biologic importance. Nancy Andrews was this like really wonderful peds hematologist, and I just love this quote. It makes me really happy. So we as hematologists think a lot about iron containing proteins, but we really focus a lot on hemoglobin. But this is just a list of some of the other proteins and enzymes that require iron. And so I think this is really important when we think about symptoms or the other effects of iron deficiency outside of anemia. Another great quote by Nancy Andrews and her co-authors of human existence is inextricably linked to iron, and disturbances in its metabolism may have dire consequences. I always think of this when I see somebody with iron deficiency. And the importance of iron is that it can donate or receive an electron. So it can either exist in its 2+ or 3+ state. And this allows it to act as a redox catalyst. And so this is really important for different reactions across the body. However, it also makes it this really reactive substance in your blood. And so it can't just be like left to roam wild. And so it's either bound to transferrin or ferritin. So transferrin is the transporter, so transferrin transporter, and it carries iron throughout the circulation and delivers iron to the cell transferrin receptor so that it can be taken up into the cell. And ferritin stores iron within cells, and it can hold up to 4,500 iron atoms. I just think about this ferritin like marching through, like carrying this giant load of iron. And then you can mobilize iron from ferritin when you need it. When we think about iron deficiency, we have to think about just what is our usual iron economy. So we get iron in from our diet, and our general body iron content is around 3 to 4 grams. And males have 0.7 to 1 grams of storage iron, but females have 0.3. And only 1 or 2 milligrams of iron enters and leaves the body in a day on average. So it comes in through our diet, and then it gets distributed across our body. And eventually some of that iron is lost each day through sloughing of skin cells, mucosal surfaces, things like that. And then for people who have menses, we lose about another milligram of iron total for each cycle. So the other big place where people can lose iron is their fetus. If they're pregnant, they steal all that iron away from the pregnant mom, and so that's a big cause of iron deficiency for people who carry pregnancies as well. The recommended iron intake for just general diet varies according to age, as well as some differences with pregnancy or lactation, and then as differences between males and females. And the recommendations for vegetarians are also higher than people who are not vegetarian. And that's partly because of how iron is absorbed. So heme iron is the iron we get from meats and non-vegetable sources, and then non-heme is the vegetable sources, and our bodies absorb heme iron much more efficiently than non-heme iron. And so we need to get iron from our diets, but sometimes that's hard. And I think it's hard to know sometimes to take a quick dietary history. Are you getting enough iron? But it's important just to do a quick, what do you eat? I'm a pediatrician, so I see a lot of teenagers. And so I always try to say, what's your favorite food? And if they're like macaroni and cheese, I'm like, do you eat anything else? And they say no, then I know that they're probably not getting enough iron in their diet. So when we think about this, so we have to think about, okay, so do you get enough iron in your diet? And then does it make up for the losses that you're having? And as we've heard in the previous echoes, we know that heavy menstrual bleeding is a really common symptom of patients with bleeding disorders. And so in the patients that we're taking care of with heavy menstrual bleeding and bleeding disorders, it's important really to be are your intakes matching your outputs from your iron? So in this study, they looked at women with heavy menstrual bleeding and people with normal menses and compared their menstrual losses through an alkaline hemotin method. So trying to see okay, do you have heavy menstrual bleeding or not? And then they were looking at what was the iron content of the menstrual losses. This table is comparing women with normal menses in the second column and women with heavy menstrual bleeding in the last column. And just, I wanted to pay close attention to their hemoglobin medians and means, and ferritin median and mean. So normal hemoglobins for people with normal menses, we'll debate whether their ferritins are adequate or not. We'll come back to that. And then for the women with heavy menstrual bleeding, a significant anemia as well as lower ferritin. So then they went and looked at, okay, what is the mean iron losses? And these tables are in micrograms, so just remember that. And in women with heavy menstrual bleeding, they had 5 to 6 times higher losses of iron compared to women with normal menses. And the median daily loss of iron with heavy menstrual bleeding is 4.8 milligrams per cycle, with some people losing more than 1 milligram per day. So just thinking about, sometimes I see these young women with von Willebrand's disease or mild hemophilia, and they're like, well, I've had my period for 7 weeks now, and I'm changing my pad every hour. And I'm like, oh my goodness, you've probably lost 5 milligrams of iron, and you don't eat any meat. And so then of course you're going to have a disconnect. So we maintain our iron absorption or our iron balance by regulation of absorption. And so that's regulated by intestinal uptake. And when you're anemic, your hemoglobin is low, the intestinal uptake can increase up to 10 times of normal. And it's your increase in that absorption is responsive to iron status, your bone marrow's demand to make more red cells, hypoxia, inflammation. But loss of iron is unregulated. You can't just be like, I'm going to turn on this faucet and let iron out. But it's through sloughing of cells, bleeding, pregnancy. So when somebody comes in and they're iron deficient, I think about, okay, are they anemic? Are they increasing their iron demand? If they're not anemic, but they're only iron deficient, the body isn't very efficient at increasing that absorption, because the response to increased absorption is based on like your anemia. So things can help you absorb iron, like red meat, vitamin C, or ascorbic acid, being iron deficient and anemic, and then fasting. And then certain things can hinder your iron absorption. So vegetable fibers, teas and tannins, phytates, phosphates, cow's milk, antacids. I can't tell you how many people I've talked to, and I'm like, oh, tell me about how you take your oral iron. And they're like, oh, I take it in the morning with my yogurt and my tea and my Pepsid. And I'm like, okay, well, none of that iron actually went into your blood. And let's reevaluate how you're taking this iron. So how do you become iron deficient? As I said, either not enough in, too much out, or you're not absorbing it well. So not enough in, you have to think about the iron demands and needs. As I said, I'm a pediatric hematologist. So I think about, did somebody just go through a growth spurt? Did they need a ton of iron? Are they a marathon runner? We know that runners have a much higher iron need, partly because when you're hitting the pavement, you're breaking down some red cells, and that can cause some increase in anemia. Are they pregnant? Are they not getting enough iron in? And then too much out. Did they just have like 3 in a row of 10-day long heavy periods? And then for our other patients with bleeding disorders, are they also having nosebleeds or gum bleeding or other sources of bleeding? And then it's really important for everybody, whether bleeding disorder or not, to think about GI sources of blood loss, or so things like ulcers or polyps or other things going on. This is especially important in the older population than what I see, but to consider screening for things like colon cancer. And then we can also see inadequate absorption. So if somebody's had a history of an intestinal surgery, so iron is absorbed in the duodenum. And so if they've had a surgery in the upper intestine, we have to think about that. Thinking about other medications or food interacting with iron absorption. Celiac disease, it's really common to be iron deficient, so it's something to consider screening for. And then rarely we can see disorders of iron absorption due to mutations in a gene called TMPRSS6. Those are really rare mutations. I think a lot of people are like, I'm a bad iron absorber. And I think it's not because they have mutations in their iron absorption genes for proteins. It's more because our bodies just are really inefficient at absorbing iron, especially when you're not anemic. Iron metabolism can be messed up by chronic disease and ongoing inflammation. So consider that too with patients who have other chronic illnesses. Iron deficiency is super common. I don't know about you guys, but I feel like this is all I do is take care of iron deficiency. It's becoming like the most common thing I treat, it feels like. And so in this now kind of older study in the 1988-1994, this was from NHANES data. They looked at almost 25,000 patients in a cross-sectional survey. And these data we can see based on both sexes, and then females and males in those orders. We can see iron deficiency and then iron deficiency anemia. And it's much more common in females, and especially in the 20 to 49 age range. And this prevalence data corresponds to 7.8 million with iron deficiency, with 3.3 million being anemic. I'm like, man, women are tired and need some iron. Let's help them. Also, globally, this is a big problem, right? So global anemia prevalence in women 15 to 49 was almost 30%, which is equivalent to 500 million women worldwide. And in the United States, prevalence has increased from 7.8% in 2000 to 11.8% in 2019. And for that data, the severely anemic hemoglobin less than 0.8 or less than 0.8, less than 8 was 0.2%. Moderate anemia with a hemoglobin of 8 to 10.9 was 4.4%, and mild anemia was 7.2%. So still really common to see even anemia with 7.2% of this population having anemia. They're one of the like the most what's the word? The clinics with the longest longevity of combined hematology, gynecology at UT Southwestern looked at their patients that they were seeing in their clinic and looked at iron deficiency with and without anemia. And 1/3 of this population had a bleeding disorder. So in this group, 36% had iron deficiency anemia, 29% had iron deficiency alone, 65% had one or the other, and 19% had received a red cell transfusion, and 38% had received IV iron. I think if we can avoid those red cell transfusions, that's great. And part of that is doing some early screening for iron deficiency, which we'll talk about here. There's also this great review from Canada looking at patients with von Willebrand's disease as well as other bleeding disorders. And there was about 417 patients in this cohort, and 22% of the females with von Willebrand's disease had iron deficiency, and 15% of females with other bleeding disorders had iron deficiency, while only 4% of males with von Willebrand's had iron deficiency. I know the majority of you mostly probably treat women, but I do think that it's notable that 4% of males still had iron deficiency, which is still a lot for the male population. But a huge portion of our patients with bleeding disorders are experiencing iron deficiency, and most of that is likely related to heavy menstrual bleeding. So let's talk about labs. I love this slide of just thinking about iron. And so that's probably like what I like to think about, but you might not. But this looks at, so there's these images thinking about iron stores and how much circulating iron we have. So I think about your ferritin is like your savings account of iron. It's where you go when you're running low on cash, which is like your hemoglobin. So I think about your hemoglobin is just like what you have to spend, and then you dip into your savings account to fill up your wallet with cash. And so we think about just normal, and we know that there's a good amount of iron in your bone marrow. Your ferritin is normal. You have a normal hemoglobin. Your red cells look normal. Everything's looking good. And then as you lose your iron stores, your bone marrow starts to not be able to make red cells as well. And over time, you develop an iron deficiency anemia with characteristic findings on peripheral blood smear of these tiny red blood cells that are pale. But I think this ferritin is the number we need to pay close attention to. And I, as the hematologist, like to look at their blood under the microscope. But the main thing we'll look about is their ferritin. And this is a little bit controversial as far as when we define iron deficiency based on ferritin. There's going to come back to the controversy in a second, but this study was another group of females with heavy menstrual bleeding in Ohio, and this was looking at iron deficiency again, and 50% of these patients had iron deficiency and 25% were anemic, and only 23.6 had microcytosis. And I think conventionally we think about this, MCV, or your mean corpuscular volume, so how big your red cells are, and say if your MCV is low, then we should think about iron deficiency, but otherwise we shouldn't. But it's not clear that that's like going to be your earliest marker of iron deficiency, and so you can't always use your MCV as your defining kind of indice, and you should always get a ferritin to make sure about iron deficiency. So my absolutely orders for iron deficiency are it's your CBC. So you can say, is there anemia? Is there not anemia? You may or may not see microcytosis, and your ferritin is your most sensitive marker. You could also order a total iron binding capacity, which is high in iron deficiency, but it can be affected by body protein levels. So if you have somebody who's really sick, they might not have a high TIBC. Your transferrin saturation and your serum iron are a little bit less helpful. Serum iron is your recent iron absorption. Like, did you eat a steak yesterday? it will be normal. And then your transferred saturation is calculated based on your serum iron. So it can give you kind of a false idea based on your serum iron. So, okay, let's talk about the controversy. In 2020, the WHO kept their definitions of iron deficiency as a ferritin less than 15 for adult females. And really what people, like, there was like uproar in hematology world. They were like, no. And this was, the uproar was because they thought it was reflected more advanced iron deficient erythropoiesis. Like the bone marrow was already starving. 15 is too late. And so there was this publication in 2021 evaluating some of the NHANES data, and they recommended a ferritin of less than 25 for non-pregnant women. And that's thought to be the onset of iron deficient erythropoiesis. So you're catching the bone marrow as it's starting to become iron poor. And then there was also a 2021 publication evaluating the hormone hepcidin, which is a hormone that regulates iron absorption. And they said we should really be aiming for a ferritin of 50. And that's the point at which the body starts to upregulate iron absorption, although not super efficiently. So this was like very controversial. I have used 25 for my teenagers if they're feeling great. If they feel crummy and their ferritin is 25, I'm like, well, let's try to get to 50 and see if we can help you feel better. But there's lots of reasons to feel crummy. And so we have to think about that as well. Iron deficiency symptoms, we often see paleness, fatigue, headaches, but we don't often see things like passing out. And then we can also see lots of different forms of pica, most commonly pagophagia or ice eating, but there's all sorts of things out there. And I like to ask people what kind of funny things they're eating and then keep track of it. And because I think it's just interesting, and why does the body do that? My clinical observations of symptoms, I always just say, like, you got the blahs. And I think that people often feel really fatigued rather than tired. And so I try to get at this by saying, if you slept all weekend, would you still feel tired? Like I said, I see a lot of teenagers and there's lots of fatigue in teenagers, but they often will say, oh yeah, no, if I slept all weekend, I'd feel better, but I just don't have time. And so if they don't feel better, I think of that as fatigue. Sometimes we'll see worsening symptoms of anxiety and depression with increasing challenges of attention. I see that clinically, and it's also been shown in various studies. Sometimes we'll see exercise intolerance. And then, like I said, sometimes it's really challenging to sort out amongst all the blah-inducing things in the world if it's iron deficiency induced blah or not. So I always say, just check for the iron deficiency, treat if present, and then you just remove at least that as a contributing factor. There's many studies evaluating quality of life and iron deficiency anemia. I'll just review one here, which was a convenience sample of a group of women in Japan that were adults, and they assessed the health-related quality of life with the SF-36. And in this group, the mean age of the cohort was 43, and 47.8% had heavy menstrual bleeding as the cause of their iron deficiency. And the mean hemoglobin was 9.2 with a ferritin of 3. And in this study, they looked at these different health-related quality of life scores. And so there's like physical functioning, physical, emotional, social functioning, mental health, pain, vitality, and general health. And then they looked at scores at 10.0, and then 1 month after iron deficiency treatment and 3 months after the iron deficiency. And you can see that these scores increased significantly over time with the treatment of iron deficiency. And this is just one of many studies demonstrating this. I also spend a lot of times talking about iron deficiency in school, right? Like most of my patients are hopefully in school. And this is a study, again, from that NHANES data, looking at school performance and the percentage of children scoring below average by iron status. And in this case, the patients with iron deficiency without anemia, as well as iron deficiency with anemia, scored significantly lower on math than they did than the patients with normal iron status. And so I think that's really important to pay attention to, especially for our young women with heavy menstrual bleeding. So let's talk about treatment, and then we'll move on to some cases. you got to stop the cause. So if they're having heavy menstrual bleeding, I always tell people, like, I can pour all the iron into you, but if you're bleeding, you're still bleeding 10 days in a row with changing your pad every hour, it's not going to help us. We're just going to be chasing our tails. So you got to stop or decrease the bleeding. Address dietary needs. This is really hard. I just feel like nobody eats enough iron. And so trying to think about, here's some easy things you could do. And then while heavy menstrual bleeding is typically the culprit in the patients that we're seeing, it's important to ask about other symptoms of bleeding, especially about GI symptoms. And then we either give oral or IV iron. So for oral iron supplementation, the convention, like previously, was to give like a ton of iron and like be like, you'll never go poop again. But now we've like tried to like remedy this a little bit. And so this was a study looking at dosing of oral iron in patients who were iron deficient but not anemic. And they were given different doses of iron at different frequency, and then they looked at iron absorption and hepcidin levels. And they demonstrated that twice daily dosing increases hepcidin and then decreases iron absorption. And they actually found a pretty similar effect with daily dosing as well. And in this study, they identified that absorption is improved with every other day dosing. And this finding has been confirmed in other studies as well. But again, it's important to remember that this study was done in non-anemic women, but they were iron deficient, so their ferritin was low. So this is a reasonable strategy in iron deficient but non-anemic patients. So for oral iron, I typically will dose with 44 to 65 milligrams of elemental iron every other day. And I think about considering daily for a while if they're anemic, maybe like when their hemoglobin's 10 or less, to try to take advantage of that increased iron absorption. And with regard to formulation, whatever the patient will take. There are gummies, there are chewable, there are liquid. I keep a running list of what patients have told me they tolerate, so I can tell other patients what they will. Whatever they want to try, just take it. And it can be with or without food. On an empty stomach is best, but if they are taking it with food, avoid calcium, and they could add vitamin C to help with absorption. And then definitely avoid taking it with teas and coffees. For IV iron, the indications are unable to tolerate or take oral iron, inability to absorb oral iron, or difficulty keeping up with blood losses. So if they're like, haven't quite figured out what they're going to do for their heavy menstrual bleeding, sometimes giving them some IV iron to get their levels up so that they can like deal with their period is helpful. IV iron, I think, has this like historic, like very scary thing, and it's based on older preparations where the free iron was like left to roam, because we know, right, that it's like this redox catalyst, and so now it's well connected to sugars, and we see way less problems with IV iron than we have historically. There is a risk of allergic, including anaphylactic reactions, but that's very, very rare. You can see this reaction called a Fishbane reaction, named after the doctor that identified it, which results in flushing, myalgia, a sensation of fullness in the throat, which is very scary, right? It sounds like an allergic reaction, but it's not an allergic reaction. You can stop the medication and it'll get better. Sometimes we can see fevers, arthralgias, myalgias, but that's rare too. In general, pre-medication is not needed, but it's recommended in patients with multiple drug allergies, a history of asthma, or history of inflammatory arthritis. And it's recommended to use either a steroid or an H2 blocker rather than an H1 blocker. And I listed most of the irons here. There's actually a new one that just came on the market, I think. So I listed them here. And any of these, it just depends on what your institution has available. And there's advantages and disadvantages. So like iron sucrose, you have to give multiple doses, but like ferric carboxymaltose, you often can give one dose. And so there's just different advantages. Some of them have more pediatric data than others. We use a lot of iron dextran at our institution, but that's just what we're familiar with. So they're all reasonable and well tolerated. The response usually is in 1 to 2 weeks after starting oral iron, you start to see an increase in your reticulocytes, and your hemoglobin should increase by 1 gram if you start out anemic. And by 3 months of oral iron supplementation, your anemia should be corrected if the cause has been corrected. Otherwise, you're just going to be chasing your tail. And then for IV iron, I usually wait at least 4 to 6 weeks after I give the iron to check a ferritin due to some interference with lab assays. And if anemia or ferritin are not improving, consider ongoing blood losses or other causes. And then we'll just quickly see study of adults who donated blood and were found to be iron deficient, which is like, oops, don't donate blood if you're iron deficient. They were randomized to receive IV iron versus oral iron, and they looked at symptoms pre and post treatment. And this was 178 individuals. And they found overall significant improvement in fatigue, as well as restless leg symptoms and sleep quality, and significant decrease in headaches, dyspnea, dizziness, and palpitations. And then if one more study, this was looking at IV iron or placebo in women with ferritins less than 50, but a normal hemoglobin. And this was to determine the efficacy of iron in decreasing fatigue. And at baseline, there was no difference in fatigue score or ferritin. And then for patients with a ferritin of less than 15, fatigue improved in 63% of the iron therapy group and 34% of the placebo group. So some additional iron thoughts. Individuals with heavy menstrual bleeding have chronic iron deficiency and then episodes of acute blood loss on top of that. MCV is often not helpful in predicting iron deficiencies, and patients may be so used to being iron deficient, they aren't reporting many symptoms, and early intervention could prevent the acute presentation requiring red cell transfusion. Oral iron is hard to take. If you can get IV iron, it's faster and easier. I give a lot of IV iron as a result, and sometimes demonstrating iron deficiency can help someone realize that they are losing a lot of blood. So iron deficiency is common. It's even more common in patients with heavy menstrual bleeding. And remember that heavy menstrual bleeding is a very common symptom in patients with bleeding disorders. People will experience fatigue, headaches, restless legs, eating ice, dizziness. Always get a CBC and a ferritin at the very least. And low hemoglobin plus low ferritin equals iron deficiency anemia. Some labs don't say a ferritin is low until it's less than 50 or 15, and I recommend considering a ferritin less than 50 as low if patient is feeling blah, especially. Okay, it was a whirlwind of iron deficiency.
So Kristina, that was excellent. Thank you for that great review. Before we do the post poll, actually, it looked like you had a question from the audience. So do you have experiences with I'm going to probably say this wrong, ferric maltol? Clearly, I don't know how to say that. She found it's better tolerated, or he or she found it's better tolerated than other oral supplements.
I don't. That's a good one. I will have to see. I think it's really like, so some people really, it's hard, right? Because you can like find a variety of iron supplements on the internet and see what is available. And so it's just looking at, does it have enough elemental iron? So you want to get to that 44 to 65 milligrams a day or every other day, depending. And some of the iron supplements I found online, they have not a ton of iron in it. And so you have to take like so many pills or doses, and then it can get really expensive. And so for our patients, like, that maybe can't afford to say, buy a bunch of different iron supplements and try them. That's why I keep a running list. So I'll add that one to the list. It's good to know.
Great, thank you. All right, lead us through our post test. Let's see what people hopefully learned from your session.
Okay. Do I give the answers as we go? No, we open the poll. Okay. Sorry, you guys, I'm really just learning how to do everything. Okay, so we'll go through. I'm just gonna let everybody, looks like people are putting in their answers. So the first, we'll give it a second. I don't feel like I need to reread these questions again.
No, I think you're good. Yeah, hopefully everyone, you can just, it's a little confusing, but basically go ahead, answer the questions again, sort of based on kind of your knowledge after the end. And let's see, once they're all submitted, it should pop up results and we can see if we changed kind of your thoughts on how you would manage these situations.
Great, thank you. Sorry. Give it a second. Everybody's answering.
All right, and Whitney, can you share the answers with us?
All right.
Great.
Okay, so according to a 2014 study, women with heavy menstrual bleeding, C is correct, 5 to 6 times the amount of iron losses. And then, which of the following hinders iron absorption? Dairy products. So delicious, but not good for iron absorption. Okay, and then number 3, according to a 2013 review of von Willebrand's patients, 22% of females had iron deficiency, while 4% of men. And then this one, for which of the following is not a very frequent symptom of iron deficiency anemia? The answer is syncope. I also would say dyspnea is not a super common, but I think headaches often are, but I don't know if it's that everybody's just tired of all the world right now, and so everybody has a headache. It's hard to decide. Great. Okay, so